Afternoon, everybody. We'll go ahead and get started. We are excited to have each of you join us today as we discuss the new Bree report on perinatal behavioral health. My name is Emily Noodleman, and I am the Transformation and Community Partnership Manager at the Bree Collaborative. Each year, the Bree develops a report on key health topics facing Washingtonians. Our members identify healthcare services with high variation in the way that care is delivered, that are frequently used but do not lead to better care, or patient health, or that have patient safety issues or inequities. For most topics, we form a work group of subject matter experts and leaders to develop evidence-based guidelines. The guidelines take into account existing quality improvement programs and the work done by other organizations. Our reports provide guidelines for multiple audiences, such as clinicians, health delivery systems, plans, purchasers, and others, to encourage collective action to promote optimal health for Washingtonians. The Bree Collaborative forms work groups to bring together individuals across the state to engage in providing their expertise to help craft the report. We greatly appreciate our work group members' willingness to share their time, knowledge, and expertise with us. And today we look forward to hearing from some of them and sharing the report with you all. We hope by the end of the meeting, you will leave with a greater knowledge of the Bree Collaborative and the report on perinatal behavioral health, learn more about collective action to promote perinatal behavioral health in Washington State, and deeper understanding of what different audiences within our healthcare ecosystem can do. During the presentation today, we will provide an overview of the report, hear from individuals representing different audiences within our healthcare ecosystem on how they intend to implement the guidelines in their role. And we will then transition to a Q&A. At the bottom of your screen, you should see a box that says Q&A. Please place your questions there during the presentations, so we then may review these questions with our panelists at the end of all of our presentations. The webinar today will be recorded, and we plan to send out the slide deck and the recording to you all via email if you signed up to attend today's event. The recording will also be posted on the Bree webpage. So as an introduction to the report, the perinatal behavioral health topic was selected by the Bree Collaborative members in September 2022, and the work group of clinical and community experts met from January 2023 to January 2024. The work group recognized that postpartum depression is common, impacting between 10 to 15% of gestational parents, while postpartum anxiety disorders are estimated to occur in about 21% of gestational parents. Pregnant and postpartum individuals with mental health concerns are at a greater risk for substance use and abuse. According to the Washington State Maternal Mortality Review Panel on maternal deaths between 2017 and 2020 report, the leading underlying causes of pregnancy-related deaths were behavioral health conditions at 32%, predominantly by suicide and overdose. The perinatal period defined in our report is including the time from conception until the end of the first year after birth, which involves significant physiological and psychological changes. The work group acknowledges that not all pregnancies end in the delivery or live birth. Both pregnancy and parenting are life-altering events that may result in new or increased behavioral health symptoms for the person who is or was pregnant, like the gestational parent. The families or individuals affected by behavioral health concerns during the perinatal period are also affected. Behavioral health diagnoses can be disruptive and concerning to the person experiencing them and have a negative impact on the fetus and newborn, as a strong predictor of infant health is the well-being of the parent. The term behavioral health includes both mental health and alcohol or substance misuse, such as opioids. This report is comprehensive of efforts to promote perinatal behavioral health in Washington State, however, is not exhaustive of every person, role, intervention, or program to support a person experiencing or at risk for perinatal behavioral health concerns, and does not include guidelines directed at every audience who works with perinatal patients. We recognize this topic is very vast and there's many people impacted by this, and so we did our best to have a report that's kind of a starting place and just highlight some of the work that can be done. During the course of care, special considerations may need to be taken for people such as, but not limited to, individuals who experience a miscarriage, stillbirth, abortion, termination of pregnancy, high-risk complications, preterm delivery, those with infants requiring intensive care, and or from communities who experience marginalization and racism. Each person requires care tailored to their unique identities, needs, desires, and lived experiences. The healthcare ecosystem is responsible for educating, supporting, and taking care of patients and families in attaining their desired care. The report has focus areas that are organized around general processes to identify a person with or at risk for perinatal behavioral health needs and ensuring they receive appropriate treatment and follow-up care. To identify focus areas, the work group relied on existing guidelines from ACOG, American Academy of Pediatrics, the Agency for Healthcare Research and Quality, available evidence, and expert opinion. You can see the focus areas for the report are around education and communication, integrated behavioral health, care coordination, community linkages to social programs, and expanded team roles. Under each focus area, there are action steps such as universal screening, brief intervention and referral to treatment protocols, coordinated treatment for pregnant and postpartum individuals, and roles of community-based and additional perinatal providers and support for PBH. These action steps are further detailed in the report and referred to as guidelines. The Bree Collaborative Guidelines are actions to be taken to improve healthcare for specific areas within our healthcare system. Today, so we have the Perinatal Behavioral Health Report, or commonly referred to as PBH report, was published just a few weeks ago, and we're really excited to hear from some of our workgroup members about this report. They've been asked to share how they plan to utilize the report guidelines in their role or organization. And again, you can ask them questions and we'll review this at the end. Today, we will hear from Dr. Mary Ellen Maccio from Valley Medical Center, Dr. Josephine Young from Premera Blue Cross, and Colleen Daly from Microsoft. For our guidelines, we have quite a few different audiences that we've wrote guidelines for, and you can see those that are in bold are those that the individuals who are speaking today represent. So I will now transition over to our first speaker, Dr. Maccio, on how clinicians and outpatient care clinics can use the guidelines. Mary Ellen, I believe you are still on mute, so I'll have you come off mute and then we can all hear you.
Thank you. Thank you. I'm Mary Ellen Maccio. I'm a family physician, but I have worked in an OBGYN group for the last 20 years. And during that time, I've developed a strong interest in perinatal mood disorder. Participating in the Bree work group on perinatal mood disorder, or PMD, has been a really rewarding experience. And I'm pleased to be the individual from the work group representing the clinical recommendations. So in terms of background, as Emily mentioned, it's really the rising maternal mortality rate in the United States that has brought PMD to the forefront. In 2023, both nationally and in the state of Washington, suicide plus accidental overdose accounts for the largest segment, approximately 20% of all maternal deaths. This is a staggering statistic and represents a real crisis. But this is really not a new problem. As early as 2008, the American College of Obstetricians and Gynecologists warned of the harm of untreated perinatal mood disorder. We have ample data that untreated perinatal mood disorder is associated with increased rates of preterm delivery, low birth weight. Individuals with untreated perinatal mood disorder are more likely to engage in harmful substance use and are less likely to follow through with prenatal care appointments. In the postpartum timeframe, individuals who have untreated perinatal mood disorder have increased rates of problems with bonding, and then offspring have problems with emotional regulation later, may have problems with emotional regulation later in childhood. So as a way to try to move the needle on this problem, in 2015, ACOG recommended universal screening for perinatal mood disorder. Then in 2016, U.S. Preventative Services Task Force also recommended universal screening, and other professional organizations quickly followed suit. the validated screening tools that are recommended, the EPDS and the PHQ-9, have a question regarding thoughts of self-harm. And when self-harm is endorsed, it should trigger formal suicide screening and a formal development of a safety plan with the patient. So as you can see, this universal screening should have had some impact on suicide rates, but it has not. One of the caveats about universal screening is that it was recommended that it only be done when there were clear treatment options, and that is really the issue here with perinatal mood disorder, is this lack of perinatal behavioral health care options. I think of 2020 as being the universal experience of perinatal mood disorder. I cannot think of any patients that I or my partners treated during COVID that were not impacted by, did not have their mood impacted. So even patients who had the very best of resources were isolated. They were unable to access their usual support systems. And there was a great deal of fear of the unknowns about fetal and neonatal COVID. And at the same time, OB clinicians were struggling to just provide very basic care. Systems in labor and delivery had to be dramatically altered to account for the infection risk. And so we had increasing rates, increasing symptoms of perinatal mood disorder, and the clinicians had very little bandwidth to address it. So here we are in 2024, we continue to have the same challenge. Perinatal mood disorder has become the most common complication of pregnancy. It's actually more common than gestational hypertension and gestational diabetes combined. And yet we're still grappling with how to address this, who should be addressing it, and what are the best treatment options. It's important for people attending to understand that perinatal mood disorder has not previously been a part of the scope of practice for OBGYNs. It is typically not addressed in residency programs. And although there are perinatal psychiatrists to help patients with perinatal mood disorder, that is problematic, not just because there's a lack of access to perinatal psychiatrists, but more importantly, there's an enormous stigma for a perinatal or for a pregnant or postpartum individual who has been screened and found to have a mood disorder. The stigma of the traditional model of being referred to specialty care, psychiatric care, patients are naturally fearful and hesitant to follow through on those referrals because they may be concerned that it calls into question their capability as a parent. So here in this environment, I'm very grateful and lucky. We're all lucky that the Bree Collaborative took on this topic because it's timely and important. So next slide, Emily. So a brief review of our guidelines, the clinical guidelines, and we hope you'll look at the full report, but it's imperative that everyone in the healthcare system who has contact with patients, pregnant and postpartum patients, receive education about the scope of perinatal mood disorder and treatment options. The message here is it's common and treatable. We're lucky to have free educational resources through the national organization, which is PSI, Postpartum Support International, and our state organization, Perinatal Support Washington. They both offer free training on perinatal mood disorder. And then for substance use disorders in the perinatal population, SAMHSA has excellent free training. In terms of screening, We recommend that all patients be screened using a standard tool such as the EPDS or PHQ-9. And as I mentioned before, this does get at the risk of suicide. It's very important that screening be done at set intervals. After universal screening was recommended in 2015, we began to look at how universal screening was being implemented, and there were several studies that showed that when it was not, when set intervals were not recommended, it was non-white patients who were screened more often and yet referred for treatment less often. So for equity, a clinician or a group or an institution really needs to choose set intervals, for example, screening antepartum at 28 weeks and screening postpartum at 6 weeks. What do clinicians need? Clinicians need ready access to and up-to-date resources for perinatal behavioral health interventions. Most patients will prefer to try therapy or non-medication interventions first. And here I want to give a shout out to the amazing organization, Perinatal Support Washington, which is available for everyone in the state of Washington. We have links to their website in the report, but Perinatal Support Washington provides a wide variety of resources for patients that clinicians can share with patients to access. Clinicians also need intensive sessions on medications, and also we're very fortunate to have the perinatal UW Perinatal Psychiatry Department, which has developed a center called PERC, Perinatal Education and Resource Center. And this is, again, available to all clinicians in the state of Washington. There's a direct consult line where clinicians can call to ask their questions, get advice about medications and diagnosis, and then their website has a great deal of information and free training. What patients need is viable treatment options. As I mentioned earlier, the stigma of the traditional model really prevents patients from accessing perinatal behavioral health support. We really need to be more creative about the options for patients. Next slide, Beth. So I'm now briefly going to review the experience we've had at Valley Medical Center in implementing perinatal behavioral health, addressing perinatal mood disorder. So in 2018, our OB leadership recommended formal mood screening at the postpartum visit. It was included as part of our EPIC checklist for our postpartum visit. Unfortunately, this was not paired with treatment options, which turned out to be extremely stressful for patients and clinicians. They were identifying a problem that they could not address. So within our large group of 12 physicians, there were a few of us who were comfortable addressing perinatal mood disorder, and of course, all our colleagues referred to us. In 2020, the number of those referrals exploded during COVID. And those of us who were doing that work, trying to directly address perinatal mood disorder, were really very overwhelmed. We were using the UW perinatal consult line all the time. And luckily, we were then introduced by Dr. Amrita Bhatt at UW Perinatal Psychiatry. We were introduced to the collaborative care model as a way of dealing with this crisis for our patients. In 2021, we were able to get approval from Valley administrators for a perinatal behavioral health integration program. We called it PBHIP. We do call it PBHIP. And the reason this was approved so quickly was because of the work that Dr. Jennifer Braden had already done in the preceding years, establishing a primary care, collaborative care program. Collaborative care has been used in primary care for over 20 years, and it's a very different model. It's a team approach that involves a care manager. The care manager is usually either a social worker or a mental health counselor. That person does, once a patient is screened and offered the program, if they choose to participate or enroll in the program, they have a thorough mental health evaluation with the care manager. The patient's clinical situation is then presented to a psychiatric consultant. The member of the team, one of the 3 members of the team is a psychiatric consultant who then reviews the case, speaks with the provider, who's the OB clinician in this case, and gets the assessment from the care manager, and the psychiatric consultant then makes recommendations about a care plan. And if those recommendations include prescribing, the psychiatric consultant gives very clear guidelines to the OB clinicians about what to prescribe, how to have an informed consent conversation with patients about risks and benefits. So this collaborative care model really is successful. It's evidence-based and successful, and it's successful because it overcomes really the 2 largest barriers. One, patients, it's done within the prenatal clinic, so patients see it as integral and holistic. They don't feel stigmatized. And then the psychiatric consultant is helping the patient, but also directly educating the OB clinician about diagnosis and treatment. So it's been very successful. We actually were able to launch our program and enroll our first patients in September of 2022. Unfortunately, during the time between when the program was approved and the launch, there were some financial constraints at the organization. So our original 1.0 FTE had to be reduced. The care manager FTE that we have at this time is a 0.6 FTE. But in the 17 months that we've been running the program, we've had 200 referrals. We've been able to serve approximately 75 patients. The challenge is that there have been an additional 60 patients who would benefit from the program and who are eligible, but we were unable to serve because of the care managers panel being full. So the demand for the program far exceeds the care manager capacity. We are looking for ways to increase care manager FTE for the coming budget year. But I think the response from both patients and OB clinicians is that this has been a very successful way to address perinatal mood disorder. There are certain things we definitely need improvement on. We need to do a better job with following through on the formal suicide screening. We need to do more consistent screening for substance use disorder and intimate partner violence. Next slide. So key points, we hope that the taboo in talking about perinatal mood disorder will be broken, that people will get the word out. Perinatal mood disorder is common and treatable. For organizations considering taking on addressing perinatal mood disorder, please consider collaborative care. Use the University of Washington Ames Center, which developed a collaborative care model many years ago. And there is a link here to a recent presentation about using collaborative care in the perinatal population. Of course, we need to improve funding for perinatal behavioral health in our own institution. The global Reimbursement for OB care has remained flat despite a 12% increase in staffing costs. So adding a new service such as perinatal mood disorder clinic is a bit of a hard sell when the organization is grappling with financial constraints. We hope everyone will come away with awareness of the general resources available available really statewide. Perinatal Support Washington is an incredible organization, and then the University of Washington PERC, the Perinatal Education Resource Center, really is very supportive for clinicians. This is not an exhaustive list. Evergreen has a good perinatal mood disorder clinic. Swedish has been doing this work for more than a decade, so that's not an exhaustive list, but those resources are available to all people in the state of Washington. And then resources for substance use disorders. Swedish, Ballard Inpatient, Multicare just started a program more recently, Inpatient at Good Sam, and University of Washington has PCAP, which is intensive outpatient support for perinatal patients with substance use disorder. Thanks for your time. Sorry, I went over time, and happy to have questions later. Thank you.
That's great. Thank you so much. We really appreciate you sharing your experience with us. I will now pass it over to Dr. Young to talk about how health plans can use the guidelines.
Okay, great. Thank you so much, Emily. And thanks, Mary Ellen. It's amazing to hear the clinical experiences and successes that you're having. So good afternoon, everybody. Thank you for the opportunity to participate in this work group and this webinar. I am Josephine Young. I use she, her pronouns, and I'm a pediatrician and medical director of commercial markets at Premera Blue Cross. So, after being a long-term community pediatrician, I now have the opportunity within Premera to bring that clinical perspective into those health plan discussions, and also working directly with our large local and national employer groups, including our longstanding partnership with Microsoft, to discuss how health plan offerings and employer benefit design can really influence and improve health outcomes on a population level. In this work together, we recognize that health plans exist at that intersection of providers, patients, and purchasers of healthcare. And we see that each of whom bring a very specific perspective and goals to help individuals achieve their personal best health outcomes during this perinatal period. So as we were participating in the development of these guidelines, we saw a number of themes that really emerged for health plan engagement. And these, are all gathered. We saw it as gathered within the overarching umbrella of health equity. And so I may refer back to that multiple times. And so these are the ones that you see on the slide here in terms of patient-informed decision-making, because none of this matters unless the patient is actively involved and has all the information that's needed to truly make those informed decisions that are meaningful to them as an individual. Improving our data collection, improving access to provider choice, because there are a whole myriad of provider offerings that provide amazing care during this period of time. And then really thinking about, perinatal behavioral health as part of routine care, things that Mary Ellen very much spoke of, in terms of people really recognizing that this is common and it's treatable. It just needs to be identified and talked about, and be freed up from the stigma that is still, tied to behavioral health care needs. And then looking, towards what are other expansion of reimbursable services that could potentially exist. So we can go to the next slide, please. So all of these slides, I apologize, are going to look really busy, and I have no intention of reading them to you. They're busy because I just wanted to make sure that all of the guidelines that were worked on with the work group are on there. And so, going back to, we started the most important place, patient-informed decision making. And, at the heart of health equity is really understanding and respecting that patient autonomy. And from a health plan perspective, it's looking at how do we focus on supporting that informed decision making. One of the key obligations of a health plan is to really help members understand what benefits they have and how to access them to meet their own needs. If those two initial parts aren't happening, then the rest in a way almost doesn't even matter as much. And so as part of our health equity efforts at Premera, we've been really focusing with our employer groups in the commercial markets on, generally through our communication with members, to decrease the stigma around mental health conditions and to increase that awareness about the signs and symptoms, because not everybody is aware of exactly what sorts of things or how those signs and symptoms may present when there are behavioral health concerns. And this is generally, but especially through the perinatal period. And this is also already a part of our whole person assessment when we work with members that are receiving personal health support with our case managers for high-risk pregnancy concerns. So, really helping, providing the information to help members understand the differences between the different provider types. Why would you need to go to an obstetrician versus a family practice physician like Dr. Maccio versus working with a nurse practitioner or a nurse midwife or any of a variety of options of care. And it's really helping them understand what those options are. And we find that, we can put information on the website, we can outreach, we need videos, any different means of providing that information, we need to be using on an active basis to help people make that decision at the point that they need it. And also knowing that in this last piece of developing those additional pathways to understand individual social determinants of health and other environmental and cultural factors that are going to influence health. This is really where the biggest differences are going to be made. From a health plan perspective, that's actually one of our biggest challenges because we have less direct impact on that. And so we're continuing to work with through our community partnerships and really understanding where are the patients, where are our members living their lives, and helping to provide information and access and referrals in those realms. There's a couple of things I want to mention that if you're not familiar with the document that's referenced here from the Foundation for Healthcare Quality about social determinants of health and health equity, I would definitely encourage that you take a look at that, because within there is another set of guidelines and checklists of things that can be put in place by health plans, by providers, and others to really think about how we can advance all of this work together. Next slide, please. And so when we think about, advancing health equity, we need to be able to look at what is available from a data perspective. And right now, a big focus of our work within Premera is focused on looking at data collection, because how are we going to understand the disparities and differences in care delivered and received if we don't have more data about the members that we're actually serving? And so for this year, we're very much focused on working towards building out even more of that infrastructure about collecting race, ethnicity, and language data. And also in that second phase, looking at how we look at collecting SOGI data or sexual orientation and gender identity data, because it's by having all of that and being able to do our analysis along those segments that's going to really help us be able to drive and improve care very much directly. So if I can go to the next slide. And so one of the key elements in the work group was to really look at, are people fully aware of the differences between the providers, and for a health plan to make sure that there is reimbursement for those services from these different provider types. And much of that is actually governed by also scope of practice laws in Washington state. And so there is coverage for care from certified nurse midwives, as well as certified professional midwives and licensed midwives. And so that really expands that level of care for individuals if they want to receive higher level of intervention or lower. And it also helps to facilitate referrals from within different categories of providers to meet individual patient needs. And in terms of ongoing work with maintaining an adequate provider network for both direct obstetrical care as well as perinatal care, behavioral health care, those are all core components of what health plans work on a regular basis. Next slide, please. So going back to talking about, perinatal behavioral health care and what is routine within that, one is around the messaging. Again, this is very common. It's treatable, identified at the right place, but it's also making sure that there's reimbursement for those services. And within preventive services offered by health plans, some of that is guided by the United States Preventive Services Task Force. And that recommendation includes that screening for perinatal, postpartum depression, and psychotherapy interventions for pregnant individuals at higher risk of perinatal depression. And so screening and psychotherapy can occur during a well baby checkup, anytime during the pregnancy, and up to a year after delivery or adoption. And this is incorporated at Premera within our medical policy for preventive services. It's ongoing work to look at verifying whether members are getting that screening done within a certain period of time. And again, that goes again to all the data analysis and collecting information, and then with ongoing navigation and support for those who are not getting those services. And then the last one that I'll touch on in the next slide is looking at, what additional services and expansion for reimbursement do we, can we consider as health plans? And it really varies a lot there, because some of this work gets into much more complicated and challenging areas, but exactly where we need to go, just because it's hard to do doesn't mean we shouldn't be pursuing it. And so we know from data that doula services and support during the perinatal period can really make a big difference. And so we're continuing certainly to explore, either with our employer groups or for just our membership broadly, how to incorporate that down the line. We already offer reimbursement for telehealth services. And then a lot of these other bullets about care coordination and how that is reimbursed, some of that falls very much within value-based contracts and agreements that are there when we're focused on outcomes, not just the work that's being done. And we recognize that having reimbursement for some of those care coordination aspects and that partnership across provider organizations and health plans becomes really critical. And so group prenatal care, those are things that we think about and consider. And especially as people are using more telehealth support, are there other ways to group different types of care delivery? And we already offer some reimbursement for different types of home visits by nurses, but continue to explore more about community health workers as well. So I'm going to go ahead and stop there. So much work ahead, and very excited to participate in it.
Thank you so much. I'll now transition over to Colleen Daly to describe how purchasers can use the guidelines from Microsoft.
I had my mute on. I'm Colleen Daly from Microsoft. My role is to foster inclusive and equitable healthcare, not only for our employees, but the broader community. A little bit about Microsoft. We have 220,000 employees globally. 55% of our population is from a racial and ethnic minority group. The Asian community represents 37% of our US population, with the majority being South Asian. Within the US, our health plan supports 4,000 births a year, or 12 babies a day. Women make up 31% of the Microsoft workforce, which translates into the majority of babies being delivered by a partner of our employee, underscoring the importance of supporting maternal health within our broader community. Recognizing that a traditional OB office visit is not sufficient to address specific disparities, Microsoft is exploring ways to supplement maternal health care. Literature shows increasing evidence of the effectiveness of doulas on birth outcomes, but also reducing aspects such as mistreatment. We've been piloting a $1,000 per birth doula benefit with a specific focus to increase racially concordant and culturally sensitive care. In addition, we've been partnering with Maven to provide supplemental telehealth services, which include access to maternal health providers, virtual doulas, mental health providers, nutritionists, infant sleep coaches, and more. Maven is critical in virtual health in meeting the needs of specific racial ethnic groups, as it is tailored to an individual's birthing journey. Lastly, Microsoft is partnering with organizations such as the Purchasers Business Group in Health and the Bree Collaborative, which we're talking about today, to contribute to comprehensive maternal health principles and guidelines, which are focused on creating actionable ways that providers, hospital systems, and purchasers can advance maternal health. Microsoft is committed to advancing maternal health within our communities. In the context of the Bree Collaborative report, what I have on this slide and the next is the guidelines that recommendations that are put in for purchasers. And I just want to talk through each of these and then give some examples of what Microsoft is looking at and what maybe a purchaser can do in these areas. The first bullet is really talking about what Mary Ellen addressed, is really thinking about increasing access to perinatal integrated behavioral health, including the care coordination between behavioral health providers, perinatal providers, and other members of the care team. As a purchaser, such as Microsoft, we have the ability to influence how our local healthcare systems may coordinate. So a purchaser plays a key role in advocating this within the local hospital systems that are within their network and where we are putting money towards. So really recognizing the influence that you can have as a purchaser to support and advocate for these models. Cover behavioral health consultation, including virtual delivery options. We see 75% of our births leveraging Maven. So it is something that employees or individuals that are giving birth are really leveraging if they're offered that benefit. It also enables some of the hospital systems and other clinics to take pressure off of them to address some of these critical needs that patients may have. Next, consider reimbursing for additional services that specifically in a population that might lack a specific diagnosis, whether that be the screening tools, they didn't feel comfortable filling them out. They didn't feel comfortable being honest. They were worried about the stigma. So really looking at within, as a purchaser, really encouraging your health plans to remove specific barriers that require a specific diagnosis to get treatment, and really looking at how you can minimize cost sharing. Review benefits on a regular basis to ensure adequate behavioral health coverage. This is something that we look at a lot and try to look at how can we be creative. For example, our EAP plan, not only in the US, but globally, we increased the coverage from what used to be 5 visits per year to 24 visits a year. Really thinking about how within the constraints of the regulations can we ensure that we're providing access to mental health services within our plan. Next slide. Could cover diverse options for individuals to receive prenatal care. As I mentioned, there's a lot of evidence saying doulas have a benefit for individuals, specifically addressing some of the needs for specific racial and ethnic minority groups, that they can find a doula or a midwife that's more likely to be racially concordant for them. And that really provides that culturally sensitive care. And something that we hear a lot about within the maternal space is that individuals do not feel heard or listened to, or that their concerns are validated. And so they don't want to speak up. And so really looking at these alternative care pathways or diverse options of pathways, because that's where they can really find that culturally sensitive care, where they're more likely to be honest about what they might be experiencing, the issues that they might be facing. And then educating your members on what's available to them. I think often there's a stigma that you have to have the best care. I think it's really important that people get the right care. And so really helping your member base understand what does right care mean for them, because that can make a difference. And really kind of going back to basics, leveraging the midwives, home visits, doulas, community health workers, because they can play a really key role in giving people that right care. And then lastly, while this might not apply to my population, it is relevant for many, is contracting with the DOH for licensed freestanding birth centers to cover home births, including telehealth and consultation models. So that's just a little bit about, as a purchaser, really being mindful of the influence that you have within what you offer to your members.
Thank you so much, Colleen. We're now going to transition to that question and answer period. So again, if you have any questions, please place them into the Q&A box. But as we wait for those to come in, my first question to the panelists, and I'm going to stop sharing my screen so we can see everyone, is after supporting the creation of the Bree report on perinatal behavioral health, what are you most proud of of this report? Maybe I'll start with Mary Ellen.
Well, I feel really pleased about the breadth of constituents included in the report. Both Josephine and Colleen mentioned the benefits of doulas, and you know, our group has worked with Open Arms, which is a doula organization in the state of Washington that matches patients with racially concordant doulas and provides amazing benefits. It's a way, doulas give patients a voice and enable them to advocate for themselves in a traditional medical model. And this research about the benefits of doulas, shortening the length of labor, decreasing the need for pain medication, has been out since I was in medical school. But it's just amazing how slow these changes are. So it's been really rewarding to be a part of a work group that looked at things from all angles and brought in all constituents. You know, I feel really lucky at Valley. We have high-risk OBGYNs. We have myself representing family doctors, but we have the family practice residency and family practice faculty actively delivering. And then we have a strong nurse midwife program. So we already at Valley attempt to have options for patients and have an inclusive model for those, high volume 2,600 deliveries a year. But in the work group, it's been really refreshing just to see how many individuals and groups really care about perinatal behavioral health, and great that so many voices were heard.
I would say the thing that I'm most proud of is that we had a lot of conversations about recognizing that birth is a significant life event, and why that is really important to recognize, and that regardless if someone is diagnosed with a mental health condition, that this is a significant life event that is bringing in mental health issues into someone's life, just like what Mary Ann mentioned during COVID. COVID was something that made perinatal mood disorder as something that's universal, and to some extent really recognizing that during pregnancy or after pregnancy that it is a universal thing that people are going through, and so trying to recognize how can we help support the whole continuum, whether someone is diagnosed with something or whether it's just recognizing the need as to normalizing these conversations. So I think that's what I was most proud about this report, weaving that into the continuum of the recommendations and the conversations that we had about that.
Yeah, and I would say that what I'm most proud of, I suppose, is a combination of what Mary Ellen and Colleen have spoken about. It is bringing all of these voices together and recognizing that we are, no matter where we sit in this conversation, we're actually all moving in the same direction. It is more about coordinating all of our efforts together where the challenges lay. It's not like one group is trying to convince another of what is important to address here. And I think the other piece, especially in speaking about the perinatal behavioral health needs, that in general, it is just a typical part of this whole life-changing experience. I mean, you're bringing another human into your life. And so, of course, it's going to be a life-altering event. And from that perspective, we're also looking at it from the standpoint of this is part of a whole. I think it's an artificial thing to say that we have the medical, physical piece of pregnancy, and there's the perinatal, behavioral health component to it. This is all one whole experience, and I feel like our very open, honest conversations in this is really advancing that, and it's really being able to put that component more into the community and recognizing it that way.
Absolutely. Thank you all. There's a question that came in just as a quick clarification. Could you describe what is MAVEN? that was brought up in the
Oh,
presentation.
yeah, I'm happy to address that. Maven is a virtual care platform, and it is a benefit that we offer to our employees. So it includes virtual visits with the various types of providers that I listed, and it's something that is free for our members to use on an unlimited basis.
Thank you. A question that came in, I'll see who feels most comfortable answering this one is, what are strategies you see to help increase the number of mental health providers, both in general and more specifically those trained in perinatal health conditions?
I guess I might jump in to say it's a difficult question. You know, Josephine was talking about seeing this as a whole problem. It's not you know, a mental physical divide. And one of the concepts is the idea of matrescence. So instead of adolescence, this is matrescence, that every aspect of a person's life changes when they become pregnant and become a parent. And I think if you step way, way back, you know, we could say that if there were more people tuned into matrescence at the NIH or you know, National Institute of Health or National Institute of Mental Health, if we had more people with awareness of this as a major life event that needed a lot of support, then we would have more, you know, attention to this problem and therefore more perinatal behavioral health providers. But it's really been unaddressed, you know. NIH, they're very good at funding coronary artery disease. You know. Anyway, so it's been unaddressed, and there's that trickle down effect. What we value in the American healthcare system translates into what we reimburse and a whole plethora of problems. Might be cynical perspective, but
well, and I think part of the response to that answer is almost thinking a little bit about it from, I'll answer it indirectly from the standpoint of thinking about it from the medical model. I think, you know, traditionally was that you needed a physician to provide obstetrical services. Although, I mean, midwives have long been part of the, but I would say that, you know, the traditional healthcare system is, oh, you need a physician involved in these things. And I think it's sort of thinking about from a mental health, behavioral health perspective, you know, what level of licensed therapists do you need to provide the level of services? So, you know, all the different tiers within that, and then also all the way down to non-licensed providers who are providing that level of support. I mean, doulas do a certain amount of it, community health workers, there's all of it. And so where I also look to it is, rather than where we've kind of approached behavioral health from the standpoint, if somebody shows up in the ER and they're in crisis, we'll throw everything at them in that moment. You know, how do we keep backing it upstream so that when things are first recognized, just the awareness, here's the little things, we can address it here right now. So as much as we need to increase the total number of mental health clinicians providing services, we need to put as much emphasis, if not more emphasis, on what can we do upstream to help people up front, so we don't even need to, so we can really decrease the numbers of people needing counseling services later.
I'm looking at the time. I can ask one question if we can kind of move quick. I'm just curious, what is one change in practice do you hope to see occurring by organizations utilizing the Bree report on perinatal behavioral health? So if you could pick one, what would it be?
I have a suggestion. I would love for us to start building the evidence and understanding of, you know, maybe normalizing mental health visits as a standard practice of care during pregnancy and post-pregnancy. Currently, there's not a big literature evidence base supporting that. So I would love to see that to grow.
I'd like to see, more institutions using the collaborative care model because it is evidence-based and it's very well accepted by patients. It's seen as a holistic intervention within their prenatal care clinic. And it would also be great if we had enough funding for care managers so that we could include patients or enroll patients in this program who are interested, that patient choice, being aware of what their options and choice are, but patients who are interested who don't have a diagnosis can be included in the program to learn about the importance of sleep, the importance of the option for doulas, all of the things that could be done to prevent perinatal mood disorder if we had better access through care managers and the collaborative care model. Because within a traditional medical model, as Josephine was mentioning, prenatal visits are short. Midwives, I think, do a better job because they have more time. But if there is a care manager available who's skilled in perinatal mental health, and that's the collaborative care model being applied in an OB situation, it really does, it could, if we had better access and better funding, really speak to prevention of perinatal mood disorder. And like you're saying, Josephine, upstream, the ideal thing would be to prevent so that everyone has the support they need to experience matrescence.
Yes. I'm going to hang on to that term, Mary Ellen. I would add that the additional component is for all health plans to be looking at how doula services can be incorporated. And I say that with, Premera also being invested in exploring that further.
Thank you all so much. I'm going to move on to just kind of wrap us up and into closing our presentation today. The Bree report is online and is accessible to everybody if you'd like to access it. I believe we've added that into the chat. We also just wanted to let you know if you find a guideline in our Bree report that you would like support on implementing into your workplace and kind of working together and receiving some information on quality improvement skills, we are hosting a Health Equity Action Collaborative starting in May, where organizations are invited to attend and engage in this space to receive education, collaborate with peers, and learn more about health equity within those designs. So if you want to engage in that, there's a link in the chat as well. Again, our webinar is recorded today. We want to thank all of our speakers for joining us and our work group members. And I also want to acknowledge Colleen Daly being the chair of the work group for all the hard work each of them have done and helping the Bree develop one of these reports and providing their collective knowledge. We will send out again information in our email to you all with a PDF of the slides and the recording. It will also be online to be sent out. If you enjoyed this webinar and you want to learn about other reports, we have one next week on Tuesday on the diabetes care report that was just developed, and on February 29th, so 2 weeks from today, on complex discharges from the hospital setting. We also, lots of webinars right now, doing one on a Catalyst for Change webinar on value-based payment and health equity and kind of the intersection between those. As we kind of wrap up too, when you look at the report and see what you've seen today too, it can feel kind of overwhelming seeing all of these guidelines. Our work group members helped inform the design of a checklist tool. We've organized the guidelines into a level 1, 2, and 3 system to help organizations who would like to implement these guidelines figuring out where to begin. They're organized in that level system based off of what is the presumed ability to implement and kind of what is and maybe something easier to more aspirational are the different levels. Those are on our website. And also we have opportunities to, if you are implementing our Bree reports or even the PBH, let us know so we can learn more about your process and hopefully provide you with one of our implementation awards. We would be happy to kind of learn more about your process. But with that, again, we just want to thank everybody for attending today. I will send out that email shortly, probably in a couple of days, but thank you everybody for engaging on this really important topic. We look forward to sharing with you more in the future on the work that the Bree is helping develop to support the implementation and continued conversation on this. So thank you so much. I hope everybody has a great day.